Okay, so we're back. This is Senate Health and Welfare, and over the break, Jen and I sat down together thinking about the testimony that we've had and made some changes to the bill that are identified in the bill, I think all in yellow. And so, Jen, this is draft 3.2.
That's right.
And I think interested folks are in the room. What we'll do is we'll go through the bill and then there's some time. I think we do have a little bit of time that we can spend just perhaps having a little conversation about different sections, but we might have to save that for Thursday when we're back on the bill.
And I am upstairs at 10:30 on another.
That, I know that, yeah. And I know others have crunchy schedules as well. Okay.
All right. Well, good morning. Jen Harvey from the Office of Legislative Counsel. I will put up on the screen this new round. This is draft 3.2 of S-151. And as the chair said, I have noted all of the changes from the last draft in highlight. So the first change is in section 1, and this has to do with the requirement that health insurers submit with their rate filings the total amount of premium revenue expended on care coordination and management. There had been some question about what that meant, what care coordination and management meant. So we've added as defined by board. We'll have board to define what they would be looking for there. Section 2, I will just note that similar language is about to be voted out of House Healthcare on the colorectal cancer screening. So you probably see that as a standalone bill. It's not exactly the same, but the concept is the same around the U.S. Preventive Services Force guidelines, but taking out the timing pieces. So we may want to look at either aligning or removing. Section 4 is the language on sexually transmitted infections. I did make some additional changes to this subchapter in the sections that I thought were not particularly amenable to just changing the terminology for our summer statutory revision process. So replacing the term venereal disease with sexually transmitted infections, and for the definition, specifically including HPV, the human papillomavirus, because that is the main topic of discussion around the preventive services piece for sexually transmitted infection. And I said sexually transmitted infection or sexually transmitted disease. The infection is what can cause.
Is section 3 that was deleted?
It was deleted in its earlier draft. I think, yeah, no, I don't look at
track.
I know, and it's been long enough that I don't remember.
Oh, it's
Oh, it was the requiring insurer participation in multi-payer alternative payment models.
Yeah, good question.
Yes,
When we originally started going through this bill, I questioned that section, and you said that it's already in statute.
no, the treatment, minor consent to treatment is already in statute, and
Okay.
so that section has come out of, I took that out in an earlier draft.
Okay.
Minor consent to treatment is covered in existing law. Minor consent to preventive services for sexually transmitted infection is not covered in our current.
Thank you.
Sorry for you. All right, the next proposed change would be to strike section 6, which is that requirement that the insurers report annually on their risk-based capital reports, provide their solvency reports. There had been discussion about this already being reported, and nobody seemed to support it in this provision. Section 7 would be new. This would replace the section on reaching at least 12% of health plan spending on primary care and instead looking at developing a target. So this would direct the healthcare director of healthcare reform and the Agency of Human Services, and I'm on page 5, in consultation with the Green Mountain Care Board, primary care clinicians, primary care professional associations, and other interested stakeholders to develop a proposal for establishing a Vermont-specific all-payer primary care investment target. I believe this language was proposed by the Medical Society. In developing the proposal, it would have the director take into consideration design requirements necessary to secure Medicare's participation in multi-payer alternative payment models in Vermont. And by January 15th of next year, the Director of Healthcare Reform would provide the proposal to this committee and to the House Healthcare Committee. So that's a potential substitute for the primary care spending allocation language in that bill. Section 8, having to do with the Green Mountain Care Board. This is largely restoring the existing statutory language on the purpose of the Green Mountain Care Board. So you can see I've struck through what was underlined and highlighted but not bolded existing language that would be put back. The one difference would be instead of recruiting and retaining high quality healthcare professionals, change that word to attracting and retaining high quality healthcare professionals. Recruiting would be a little bit more active role in trying to get people here as opposed to perhaps making reforms for a system that would attract professionals to want to practice in Vermont. Then we have the board membership and authority, no change, and nomination process, no changes to that. The would propose on the bottom of page 10 and bottom of 11, striking the section on the Green Mountain Care Board doing mediation prior to termination of the contract between a healthcare provider and health plan. In proposed section 8B, this would revise language from the last draft we looked at, where instead of having the Green Mountain Care Board directed to develop a methodology for establishing hospital billable budgets, there was some talk about whether that was more appropriately in the Agency of Human Services. So this would be develop a methodology for regulating hospital billable budgets. Section 9 is the budget review, and this is proposing to delete the language specifying that any criteria and benchmarks that the board sets must be set at the hospital level or across the healthcare system and not at an individual cost center or service level. There have been some concerns raised about that, so this proposes to delete that language. Section 11 is the Medicaid budget, and specifically the part we've been looking at is the reporting on or striving for and reporting on increasing rates for Medicaid participating providers. So this would eliminate the references to primary care. These were some recommendations from Medical Society. Again, I don't want to put words in your mouth, but that's my recollection. So eliminating references to primary care, I've added at least the way the language had read is that it was the intent that everyone should be reimbursed in rates that are equal to 100% of Medicare rates. And it seemed that the conversation was more about making that a floor and not specifically targeting only 100%. So equal to at least 100% of the Medicare rate for the services provided. Also looking at, so in the language in the bill and its annual budget proposal, DVA is directed to either provide reimbursement rates. Nope, I missed it. The rates that are at least 100% of Medicare rates, or provide information about what it would take to get there. And based on recommendations from the Medical Society, this would change the target year that we would be using as the benchmark for the Medicare rates from 2022, which had been in the prior draft, to 2021, and also using the Medicare Economic Index as the inflation adjuster as opposed to the Consumer Price Index, which is more appropriate when talking about Medicare rates. Sure, lagging in. changed it at least. Then we get into the head model language. And this would keep the intent language, but make some changes later on. So first it would add a new subsection D, saying it is the intent of the General Assembly that the Green Mountain Care Board and the Agency of Human Services enter into an agreement with CMS for Vermont to participate in the head model if the agreement does certain things. You want
We're one over, we need one person to leave. So if you've been here a while. But, yeah, we're probably just gonna go through the bill, and then we'll probably not be talking about section.
Is it possible to ask a question?
No, no, we can talk later.
Thank you.
Okay, so it is the intent of the General Assembly that the Vermont Care Board and Agency of Human Services enter into an agreement for Vermont to participate in the AHEAD model. If the agreement builds on the hospital transformation efforts currently underway in accordance with Act 167 of 2022, advances integration of Vermont's system of care, increases investments in primary care, continues investments in the support and services at home STASH program, includes mental health and long-term care services and providers to the extent practicable, is inclusive of all Vermont hospitals at a level that is appropriate to each hospital's size and financial capacity, and provides the resources necessary to facilitate Vermont's participation in the model in a manner designed to improve population health, advance health equity, and curb the growth of healthcare costs in this state. Section 11B would replace what was subsection D, I think in the prior section in the earlier draft, with some new language and with some modifications. So this just breaks out as a separate section that in their negotiations and planning for the AHEAD model, the Green Mountain Care Board and Agency of Human Services shall identify any necessary modifications to the regulatory structures in Vermont law and recommend those in a timely manner to have them considered prior to the model's implementation. And then there's some language recommended by the healthcare advocate that is incorporated here that would say that the Director of Healthcare Reform in the Agency of Human Services shall provide input to the Green Mountain Care Board to inform the board's development of methodologies and processes for establishing hospital local budgets. Once you make some decisions here, we'll need to marry this section up so it's consistent with the 9453 language about what the board is doing with respect to hospital local budgets. In addition, the board shall convene interested stakeholders to consider appropriate processes for regulating hospital global budgets, how best to integrate the hospital budget review process, and how best to integrate Vermont's hospital budget review process with the requirements of the AHEAD model. Changes there. I've made this. I think I have section 12. This is in what is now 12A, the Green Mountain Care Board Regulatory Review and Realignment Report, and this is taking out some of the specific language in what the evaluation will be looking at. So this is where the board, in consultation with the Director of Healthcare Reform, would evaluate realignment of the timing of its regulatory processes, building and expanding on the board's regulatory alignment efforts, and the language had said that it may include considering alternative models such as, and gave some examples. This would instead just say it may include considering alternative regulatory models and still tied to the state's goals of improving the health of the population, reducing per capita rate of cost growth, and ensuring access to and quality of healthcare. That's it for the changes.
Okay. Thank you, Jen. So questions for Jen on the proposal? Tomorrow, we're going to spend some time going through the bill. And if there are folks in the room who would like to ask Jen a question or offer comment at this point, if we do that, and understanding that it's a pretty new draft, and I understand the time frame and the work that we had in front of us in a short period of time.
When do you think we'll vote on this?
Well, after we finish markup,
Correct, because. Yeah, I'm very much in favor of, the vaccine portion of the bill, but I have misgivings on most of the rest of the bill. I'm just gonna let my committee know that that's where I'm standing.
so, this is a 3.2 draft, which is pretty new.
Right,
So I think we've also heard comments from folks this morning. Jill Mazza Olson and others, and we've heard comments that would support sections of the bill, including some of the last testimony that we received from the Green Mountain Care Board. So encourage you to go through the testimony that we've had
I will.
and the improvements that we made in the draft.
I'll just say, Madam Chair, that I agree with Senator Hewlett. I have misgivings, to say the least, pretty much the entire bill. So, and I have read several times the changes.
Well, we'll hear from folks. I guess I would ask the Green Mountain Care Board for any comments that you might have on 3.2 at this point.
Sure, and my name's Owen Foster.
Sure.
The chair of the care board.
Why not sit and have a seat?
Thank you. Just for the record, my name is Owen Foster. I'm the chair of the care board and our general counsel is with us at Farmington today. And I apologize, I can't attend tomorrow. If you need me to, I'm chaperoning the Jericho Elementary School building tour.
So be looking for that.
They're wonderful kids. So. I guess I have a couple overarching comments. We submitted some comment in response to the last draft of this bill, and it doesn't really correlate perfectly with this new version.
Well, and the reason they don't is that we didn't receive those until later Friday afternoon before last weekend.
Yeah.
And we had already tried to incorporate previous comments, so there's still time for.
Right.
Grading.
All that said, I'm having a little bit of a hard time following some of the changes from 211 to the last draft to this draft. Our overarching position is that regulation, independent, transparent regulation is really important. That's how we say Vermont 145 this year. Rate requests were really high, and we want them as a state. Our goal, our policy goal, we put in the all-pair model, and we put in statute already, is to have to be an amount that we can afford. And that is important because when you can't afford healthcare, we don't get it. And it's important because we want to make sure that the whole system is really strong. So anything that really reduces our ability to independently and transparently regulate, I think is a negative. And there's a couple things in here that do that, which raise concerns for me. And we do have, and put in the context of our views, we have incredibly high expenses for healthcare, and they're really going up astronomically. Our QHP plans have gone up 58.5% since 2019. National is under 5%. Grossly disparate. We are seeing our school budget strained by healthcare costs. We are seeing our property taxes skyrocket, in large part because of healthcare costs. So my view is it's not the time to change anything about how we independently, transparently regulate healthcare. Transparency is the best part. You get all the public comment, you get all the participation, it informs us. I've said this before, but when you only hear one side of the story, you make bad decisions. So we have a process that ensures we get all sides of the story. I think that's important. So one of the main sections I was concerned about was the change to section 8B on page 11 of draft 3.2. It says the board shall, and it says develop a methodology for establishing. Now it says regulating instead of establishing. Establishing a budget is regulating a budget. They're not different. That's what we do. That's our core function. We set hospital budgets. That's the bulk of what we're charged with doing. So this one word change is drastic. If we're not establishing the budget, what's the budget? And how do you regulate a budget you don't establish? That is the core function of the Green Mountain Care Board. And it's independent and transparent. So I object to that change. I think it's a bad change for the state of Vermont. I don't think it's the time. And it's inconsistent with the entirety of what we do, and also section 11B. So there's some things that are inconsistent within this draft, and also to our current statute, also what's being negotiated in the head model, also to 167. So it's very hard to follow where things, so 167 required us to evaluate our regulatory process. This changes it, and now it's being done a different way. So it's really hard to keep those things kind of consistent. On the primary care spend, I just wanted to cite that like how you measure primary care spend can really dictate the outcome. The methodology matters. So there's one report that says Vermont's around 4% primary care, or of our spend is primary care. Another that says around 8%. Another that says we're 10.5. Well, which is it? If you're moving it had been moving it to 12%. Well, if you use a 10.5, you almost have nowhere to go. We want these changes to matter for Vermonters. We want people to feel the changes, not like math. We don't want financial engineering. We want change. And if you move up to 1% primary care, is that going to make the difference you're trying to make? I don't think it would. And
But
so,
establishing a benchmark would be helpful.
right, and I think that should be done independently, because you might have an incentive to make that number look higher or lower, right? And it really does make a huge difference, 10.5 to under 4. And people can't get primary care. I've said it before, I couldn't get a primary care provider. My wife's a nurse, I'm the chair of the care board. I luckily have one now, but that's what people experience. So you gotta think about what people are experiencing, not this. And so the report, I think, should be independent. It also butts into the regulatory side. So we have rate setting authority where we say what the rates are. We can do that. We haven't done it, we can do it. So if someone else is figuring out the methodology, but then we're trying to do rates, it might not be correlated, right? The other thing is hospitals have the majority of primary care. Well, if we set and regulate hospital budgets, but somebody else says what this budget is for this component of it, it doesn't line up. There isn't a line. And there's not role clarity. It's confusing.
So you're looking at 11B.
I'm looking at section 7, primary
Oh,
care.
okay, when you left 11B. 11B does have AHS informing, or providing input.
Yeah, so go to 11B.
Yeah.
So my understanding was the idea behind this was to help our negotiations with the feds. And I do not have experience in this role of negotiating with, I've never negotiated one of these models, but top negotiations, I led a lot of big negotiations, and we don't want the other side to know what we want. That's usually how we do it. We don't want them to know what our intent is. We want them to think that we might not do it, so you get a better deal. The other thing that we do is we define walkaway points. We say, here's what we're going to do. So I like some of these changes over here as to what we might need to see, but we need to define it. The other thing is you want alternatives. So the other side thinks you might go do something else. Like that's what we do. And I haven't done this, so it's different context. I get that, but that's a concern I have. The other thing with the listing, I don't know if it's the right set. I don't know what you're, if it's the right set of things that you want to identify. If there's others, I'm sure a lot of people have different thoughts. The other one is 11B. The only comment I really had on 11B was it's inconsistent with that other section that strikes us establishing budgets. And it's inconsistent with so there's just inconsistency things. Currently, AHS doesn't inform us on how to regulate hospital budgets. So this is again a big change, right? You're leading the lines a little bit. And you talked more previously about role clarity, and that's what everyone wanted. This blurs role clarity for them to inform us. We talked about transparency and independence being good. This blurs that. So I have concerns about that. I personally think that the independence and transparency is really critical. So having us being informed by the executive branch is a massive change, and it's not one that I support.
I think there's language in Act 167 deals with global budgets and AHS and agreements. Well, sort of coverage as well.
Yeah, so I mean, I would say this has been done. So like now we're changing, it. So that's my view.
Okay, good, thank you. That's very helpful.
Thank you.
And, we don't have time actually for further, but I know that Sheila, you're here from AHS. Did you want to offer any comments at this time?
I'll be here tomorrow, yeah.
Okay, we'll do that. Okay, thank you.
Thank you.
So the question I have is for folks in the room to offer comments for improvements on the bill as we go forward. You already have done that for some of the sections of the bill. And I would ask that you do that going forward. And then what we're going to do now is we're going to switch to
Madam Chair,
Katie, and
I think I would like to call the question on the bill.
so we're not ready for that. When we are, you can certainly do that, but this isn't the time.
I think that
So-
4 of us are ready to vote on the bill.
I understand that, but this is not. So I'm gonna ask us to move on to S-186. You'll have Katie.
So guys, some of the ones are gonna be small enough, if I did, if she were there, it's like 6 seats and one.
Before you go, I just wanna say, it seems as though, don't we have the right to call a question on the vote? We don't. The chair is the supreme ruler of the committee, okay?
I'm gonna
So-
check on that, the rules of the Senate, but,
So right now, we're going to move on to S-186.
Good morning. Katie with my Office of Legislative Counsel. I will pull up the draft.
Okay, we need to shut the door.
I get up. I can't do.
Okay. So we have draft 1.2 of S-186.
You make it just a little bit bigger.
Let's see. Oh, yes, I can. Okay. So just to sort of remind you where we are, where we last left off. This is a new draft that the committee has not seen yet. When you last took up this bill on recovery residences before town meeting week, we had looked at the bill as introduced. There was feedback and conversations with the health department and with Monica Hutt, who's the chief prevention officer. And they were to propose language about a potential certification program for recovery residences. And so this draft is based on recommendations that came back from the health department and from recovery residences. So the first section of the bill is making a recommendation on a recovery resident certification program and what exactly that would look like. First, in subsection A, the Department of Health, in consultation with state agencies and community partners, is to develop and recommend a certification program for recovery residences operating in the state. The certification program shall incorporate those elements of the existing certification program operated by VTAR. The recommended certification program shall also identify an organization to serve as a certified body for recovery residences in the state, propose certification fees for recovery residences, establish a grievance and review process for complaints pertaining to certified recovery residences. And on page 2, identify certification levels, which may include distinct staffing or administrative requirements or both, to enable a recovery residence to provide more intensive or extensive services. In subdivision 5, identify eligibility requirements for each level of recovery resident certification, including staff and administrative requirements for recovery residences, including staffing, staff training and supervision, compliance with industry best practices that support a safe, healthy, and effective recovery requirement, and data collection requirements related to resident outcomes. And subdivision 6, establish the required policies and procedures regarding the provision of services by recovery residences, including policies and procedures related to resident rights, resident use of legally prescribed medications, and promoting quality and positive outcomes for residents. In subsection B, in developing the certification program recommendations required pursuant to this section, the department is to consider available funding streams to sustainably expand recovery resident services throughout the state. Second, how to eliminate barriers that limit the availability of recovery residences. And lastly, recovery residence models used in other states and their applicability to Vermont. So all of this work would be coming back to the General Assembly by October 15th of this year. That's when the department would submit a written report describing its recommended recovery resident certification program. And the report would also contain corresponding draft legislation that would come to this committee and to Human Services. We have a definition of recovery residents that I pulled. I don't know if you remember me saying this, but there had been work for several years on a bill about recovery residences. So this definition I pulled from that work that had been done. I think the last iteration of this work was done in 2020. So the definition, as used in this section, recovery residence means a shared living residence supporting persons recovering from a substance use disorder that provides tenants with peer support and assistance accessing support services, community resources available to persons recovering from substance use disorder, and is certified by an organization approved by the Department of Health that is either a Vermont affiliate of the National Alliance for Recovery Residences or another approved organization, or is pending such certification. So you'll see that again in the next section. So the next section is an assessment section to sort of do an assessment of what exists now on the ground with recovery residences. And so this is set to occur in fiscal year 2026 because the funding mechanism, fiscal year 2026, because the funding mechanism for the work is tied to 2026. So in fiscal year 26, the Department of Health shall contract with an entity for technical assistance for the purposes of creating a comprehensive inventory of all recovery residences in Vermont, including assessments of proximity to employment, recovery, and other community resources, assessing the current capacity, knowledge, and ability of recovery residences to inform data collection and improve outcomes for residents. Third, assessing recovery residences' potential for future data collection capacity. Fourth, assessing the types of data systems currently in use in Vermont's recovery residences and defining the minimum core components of a data system. Fifth, assisting to develop a framework of critical components and measurable outcomes for recovery residences and other recovery communities. Six, assisting with capacity building and sustaining alternative payment models for recovery residences. And lastly, providing technical assistance on how to build sustainable funding with a focus on developing fee structures. And then we're using the same definition of recovery residence that I just went through in the previous section. And then section 3 is the funding mechanism for section 2. So in developing its fiscal year 2026 recommendations for expenditure from the opioid abatement special fund, the advisory committee is to reserve $500,000 for the contract for the Department of Health for technical assistance pursuant to section 2 of this act, and then capital expenses related to recovery residences.
Can I ask a question?
Yeah, I do too, okay. No, go.
The $500,000. What levers does the legislature have to request that money be earmarked for this purpose? It seems appropriate.
Yeah, we can do it, but the question is, do we want to do it? Because we worked through the process of establishing the advisory committee specifically to provide, So, I mean, that's my question too, and I guess the question for me is, should it be, shall consider reserving? Rather than, yeah,
Just.
Yep.
so it's either telling them to do it, which intrudes into the process that we currently have established in statute. Or do we suggest that it be a consideration? So, and then we probably would want to say, I don't think we need to say anymore, but either shall consider reserving or do it, Katie.
Well, I. 2 points.
Okay.
So the first is that, it sort of sets a new precedent to reserve
Yeah.
money set aside outside of the process established in statute. That doesn't mean you cannot do it, but it means that you, the General Assembly, has spent some time creating a process, and now, by having a shall, you're sort of, contravening that process. A different point is that the Department of Health, in an email asking for, some changes to the language they originally sent, wanted something along the lines of, for this technical assistance language, the department shall contract with the entity for technical assistance. I don't have the exact language at my fingertips, but something along the lines of an entity that doesn't charge for these services. So they want to work with an entity that provides technical assistance free of charge, which would therefore not necessitate any reserve, from asking the advisory committee to reserve money at all.
So then the question is, if the money were reserved, it could be used for initial fit up or capital expenditures for residential facilities. It wouldn't be an ongoing operational expense. That was the intent of that.
Was that linking,
I zoned out, so I didn't hear everything.
Okay.
Sure.
So we have recovered residences in our district and they're nonprofits. So is that what we're talking about for other entities that don't charge?
I am not sure what is intended.
I think it's the
Um,
Fletcher Group.
Is that what
I
they're
think
trying to
it's the
get at?
Fletcher
Okay.
Group being referenced because they will provide support services for all of this work free of charge, because they have a big grant from SAMHSA, a federal grant. And a federal grant allows for them to go to different states and provide support.
I don't know that you need to say in statute from a group that isn't going to charge.
So,
I
so
think
we just, yeah,
I
this
think
came
it could
from
just
the.
be silent
Yeah,
in
just
that
to
way.
remind us where the language is coming from. It's coming from Monica Hutt and from Department of Health, Kelly Doherty, who, and, worked with them before, and now they've brought us some language that fleshes out the bill a little bit. So we don't need to say that.
I think you could just say something like the Department of Health shall seek technical assistance for the purposes of,
Perfect.
and leave it at that. And then I don't think you would need the language about the opioid settlement fund.
Well, although the opioid settlement fund request is more of a request to actually allocate funding for capital improvement, initial or capital improvements to, for certification, registration, licensure, or just getting set.
Okay, so what I hear you saying is you'd like to keep this section, maybe striking out section 1 if we know, subdivision 1, if we no longer need that about the technical assistance.
Right.
And then I don't know that capital expenses would cover certification costs or programming costs. So if you
Some initial expenses that are not operating expenses. That's what we're trying to get at, what's needed to have recovery centers go forward.
do you want to just leave it at capital expenses related to
Yeah.
recovery residences?
Initial.
Initial capital expenses, okay.
Or, wait, that's a bad thing, sorry.
Initial
Yeah,
for new centers or? for
yeah,
existing
that's the
centers?
problem. It's for old and new alike. It's for, so just leave it at capital expenses. How can we put in there on something about, through a grants? That's what they do anyway. We already have guidelines for the use of that money.
I mean, if you want. This is, so you're just saying shall consider right now, shall
Yes,
consider.
yeah, we're just,
Okay,
I don't
So-
wanna intrude into the process any more than say, this is a thought.
so I could put some language there, for a grant program.
Or
For capital expenses, something like that.
one time,
Or a
one time, yeah.
One time.
So they're eligible, so right now, for example, Jenna's Promise has a $500,000 grant. And we're trying to figure out how to measure the outcomes for Jenna's Promise, what's beneficial. So this would be comparable to that
Mhm.
grant process that they have.
Okay, I have that. Okay, I can make that change. Do you wanna go back up and go through that? I mean, line by line, the new language on
Sure.
this certification
Yeah,
program?
let's do that.
Okay. Okay, so again, bill is sort of in two parts. We have an assessment and, oh, sorry, so I'm still stuck on the assessment, but if you're just doing those fiscal year 26 opioid settlement funds for capital expenses and it's not tied to technical assistance, you might want to change the lead-in language on the assessment portion. Sorry to jump around. But I added this intro because we were tying it to fiscal year 26 opioid settlement funds.
So, yeah, no, think about it, it could be related to some IT needs. So,
So I don't know that you want this to be in fiscal year 26.
no,
I can just strike that.
this could be on.
Okay. We'll just start with the department. Okay. Do you want, so where would you like to start? Since we're talking about the assessment, do you want to go
Yeah, do that.
finish with the assessment? Okay. So this would now read, the Department of Health shall obtain technical assistance for the purposes of creating a comprehensive inventory of all recovery residences in Vermont, including assessments of proximity to employment, recovery, and other community resources. Second, assessing the current capacity, knowledge, and ability of recovery residences to inform data collection and improve outcomes for residents. 3, assessing recovery residences' potential for future data collection capacity. Assessing the type of data systems currently in use in Vermont's recovery residences. And defining the minimum core components of a data system. 5th, assisting to develop a framework of critical components and measurable outcomes for recovery residences and other recovery communities. Assisting with capacity building and sustaining alternative payment models for recovery residences. And improving technical assistance and how to build sustainable funding with a focus on developing fee structures. So that is the content of the assessment. Do you want a date by which this assessment would come back to you? Do you want to see the assessment?
When is the report due?
The report is due October 15th of this year. That's the report on certification.
Wonder if we could combine that.
Okay. I mean, I don't. Yes, so we could say that they will complete it and distribute it by October 15th of 2024.
We could try, I mean, they're already working on a lot of this,
Okay.
but then we'll hear back. You know,
Okay.
they want to bifurcate it. CPG.
Okay, I can add that. And then I'll move back up to the certification piece. Okay, so the concept here is that the Department of Health is going to be working on sort of a recommended certification program for certifying recovery residences. So the lead-in language is that the Department of Health, in consultation with state agencies and community partners, shall develop and recommend a certification program for recovery residences operating in the state. The certification program shall incorporate those elements of the existing certification program operated by VTAR. The recommended program shall also identify an organization to serve as the certifying body for recovery residences in the state. Propose certification fees for recovery residences. Establish a grievance and review process for complaints pertaining to certified recovery residences. Identify certification levels, which may include distinct staffing or administrative requirements, or both, to enable a recovery residence to provide more intensive or extensive services. Identify eligibility requirements for each level of recovery residence certification, including staff and administrative requirements for recovery residences, including staff, I think it should be staff training and supervision. Or forget it. Staff training. Okay. Compliance with industry best practices that support a safe, healthy, and effective recovery requirement and data collection requirements related to resident outcomes. And establish the required policies and procedures regarding the provision of services by recovery residences, including policies and procedures related to resident rights, resident use of legally prescribed medications, and promoting quality and positive outcomes for residents. In developing the certification program recommendations required by the section, the department shall consider available funding streams to sustainably expand recovery residence services throughout the state, how to eliminate barriers that limit the availability of recovery residences, and recovery residence models used in other states and their applicability to Vermont. And then we have our date by October 15th. The department shall submit a written report describing its recommended recovery resident certification program and containing corresponding draft legislation to the two policy committees. And then we have our definition of recovery residence.
Okay, so there's a lot in that section that might require some resources for recovery residents, once all these decisions are made. So that's where I go to the maybe IT or developing assessment tools. So, yeah, okay.
So existing recovery residences that, will they get to weigh in on this?
Yeah,
Do they?
yes, and they were involved in the discussion on the language. Let's just. It was here, he testified.
Jeff Morrow.
Oh, well, thank you, Jeff Morrow. And we can certainly have them comment again. Any questions for Katie on that section?
No, just a comment, an observation, maybe. My fear is that we create a bureaucracy.
Yeah.
Over bureaucratized recovery system effort. As we may have witnessed in other social services that we've been just discussing just in my short tenure here. I understand the goal, and I support the goal. I just fear that we might be adding cost. And I just want to and I know we're doing a report, from the report that we extract how to affect that, but I just, my
we don't want to do what you're thinking.
Okay, right.
Yeah, no, I think, one of the comments that Department of Health made and the administration altogether made was maybe this should be voluntary, voluntary certification. Well, it will be. I mean, we could say it will be a voluntary system, but perhaps it's better to wait and see the outcome and recommended legislation. But I agree with you, we don't want to have all the oversight and organizational structure that destroys what happens organically, like Jen's promised.
I know that grants are tied to the financial ability of the recovered residents, and we don't want that to be affected, I wouldn't think.
No, but you do want to know that what you're providing has there are some outcomes that So with the dollars that we've given to Jen's Promise, we're trying to sort out what's the result of the passion demonstrated at Jen's Promise? And what are the outcomes associated with the actual work that's going on? We can do that with this. And Fletcher Group seems to think that we can do something. I mean, and I suggest that you go through the bill again and sort out if there's some language change you want to make there. So maybe we should go through that other section again.
The assessment? The assessment or the certification piece?
Assessment.
The assessment, okay. Okay. So, newly in language, the Department of Health shall obtain technical assistance for the purposes of creating a comprehensive inventory of all recovery residences in Vermont, including assessments of proximity to employment, recovery, and other community resources. Assessing the current capacity, knowledge, and ability of recovery residences to inform data collection, and improve outcomes for residents. Assessing recovery residences' potential for future data collection capacity. Assessing the types of data systems currently in use in Vermont's recovery residences. Defining the minimum core components of a data system. Assisting to develop a framework of critical components and measurable outcomes for recovery residences and other recovery communities. Assisting with capacity building and sustaining alternative payment models for recovery residences. And providing technical assistance on how to build sustainable funding with a focus on developing fee structures. I wonder if that last one reads funny with the new lead-in language. The Department of Health shall obtain technical assistance for the purpose of providing technical assistance. So I think we could work at 7 there. The Department of Health shall provide technical assistance. We could just strike this.
Yes, to build
Yeah, we need to start,
or something.
okay, I'll figure it out.
How to is probably.
I'm trying to do a verb and ing be consistent with the rest of the, I will figure it out. To be consistent with the rest of the items on the list. Okay. I'll make that change, and then you've decided to ask for the results of the assessment by October 1st of 24, so I will add a new subsection that specifies that.
Okay, we'll see how that flies.
Okay.
Yeah.
Then you've amended will be amending this section to remove subdivision 1, and you'll just have initial capital, oh no, we decided not to do that. A one-time grant program for capital expenses related to recovery residents.
The one time relates to the individual recovery residents. So
Give that-
so I'm trying to think, how can we have a reserve fund over a period of years that then allows for one-time investment? Because there are so many different recovery residents. I don't know how to say that.
That I'm trying to think through how to do that, because the advisory committee makes its recommendations sort of 1 year at a time.
But the guideline, and so when I talked with Commissioner Levine, he indicated that the guidelines, you might want to chat with him, but that the guidelines would allow for
Ongoing.
holding
expenditure.
on to a fund that can be used over time for startup, initial capital needs related to this, because we're not gonna be able to help every recovery center with the first year. So if there's some language that says,
Why don't I say shall consider reserving $500,000 annually to develop, no, for for a grant program. Okay, I don't know that one time should go there for
or
a grant.
support, if you're gonna,
Support
you know, that meets the assessment criteria established, something like that. No, okay.
Okay, but I just have to think
I
about
have
it.
to think about it too.
Okay,
Because I agree with the Rutland senators that we don't want to establish a bureaucracy here. What
Okay.
we're trying to do is to provide money for, if a recovery center applies for it, the decision can be made based on the information that we have about assessment, certification, and so on.
okay,
Yeah.
okay.
So I don't know if it's just, yeah, okay.
Oh, you'd rather not specify, you'd rather just in developing recommendations for expenditure, just generally?
Yeah.
Okay,
You flop it in 1 year, then we lose the opportunity.
okay. Okay, I can make those changes.
Okay, that would be good. I mean, have that next. Okay.
When, yeah, is this, I'll check my calendar, am I coming back with this tomorrow?
I don't,
It's not on my calendar. No,
when you're here with 231, you can look at it.
okay, great.
Okay, we have, oh, we're early. Does anybody want to take a break beside me? Let's